Let me introduce Dr. Lavelle. Dr. Lavelle is a board certified and fellowship trained orthopedic surgeon. He did his residency at Albany Medical Center and a spine surgery fellowship at the Cleveland Clinic. He's an avid researcher in adult and pediatric spine surgery, including growing spine techniques such as the VEPTR, which is a titanium rib for early onset scoliosis. His interests also include adult and pediatric spinal cord injury, cervical kyphosis, adult and pediatric scoliosis, spinal osteotomy, and just general spinal outcomes research. So I'd like to introduce Dr. Lavelle. You can take it from here.
Sure. Hi, good evening. I'm Bill Lavelle. I'm the Spine Fellowship Director at SUNY Upstate in Syracuse. We train orthopedic surgeons and neurosurgeons and have had a spine fellowship for quite a long time. My predecessor was Hanson Yuan, for those of you who are interested. And also, as Mike cites, Ed Benzel, as you probably heard, I was a Cleveland Clinic guy, so it's like the 7 degrees of Ed Benzel. So I'm also of the Ed Benzel lineage, even though I'm an orthopod. So you heard a whole litany of things that I do. It's one of the reasons why I stay at a place that I'm at is that I get to do all that kind of stuff. That being said, still a good part of my practice is degenerative spine surgery. And one of the things that we recognize with any kind of spinal fusion is that the indications for surgery can be debated. The techniques, you can do a variety of different techniques to do spine surgery and spinal fusions. One of the things that we all inherit, and it seems even over the past 12 years that I've been faculty, is that the people get sicker, they come with more adversity. And while it would be nice to fuse healthy 38-year-olds, that's unfortunately not what a lot of us wind up doing. The patients get sicker. Medicine's done a better job of keeping people around, but it also makes it such that they demand more. So somebody who has substantial morbidity wants to have a functional spine. They want to be able to walk. They want to be able to function. And those demands place a higher burden on us as surgeons to be able to provide them with that. We're also faced with an environment that falls under a great degree of scrutiny. Mike had talked about bone morphogenic protein. I like bone morphogenic protein. I like it because it makes bone appear on the x-rays. But for those of you who know a little bit about the history, and I'm sure many of you do, BMPs have seen a tidal wave of acceptance and then concern. Marshall Yurst described BMP, and it was described actually in an initial positioning of it being heterotopic bone. So BMPs are identified as a way to form bone in pockets of muscle. And one of the things that we, as reconstructive surgeons, are mandated to do is to provide a functional reconstruction. And so you have to really be critical of just laying down bone in a place where it's non-functional. So I think, like the slides you've seen previously, where the attempts are to bridge bone in between the vertebrae themselves with anterior procedures are very rewarding. And while the literature may be vexed about what's the best way to do it, we're not really confused about what's the worst way to do it. So to take someone and to do a reconstructive procedure and have them ultimately not fuse is a concern. To have them develop foraminal disease from things like heterotopic bone formation is a concern. And trying to balance that with economic healthcare concerns and costs is a problem and a challenge. Next slide, please. And so amongst the myriad of things, I could show you tumors, I could show you, reconstructive procedures. The vast majority of us deal with this, even if we do other things. And surprisingly, it's not an issue for you to think about this patient who's common to all of us, a 50-year-old with longstanding back pain and radiculopathic pain, who has a fractional, almost olisthetic lumbar curve, which means one of the vertebrae is translated to the side. and has a combination of back and leg pain. Next slide, please. And so what you see from the sagittal MRI scan is a patient with substantial foraminal stenosis, 2-level disc degeneration. To tell you that I would do a spondylectomy on someone and have you have a concern about a non-union, you expect that to be a concern. Something like this, you know, your patients are demanding. I mean, they expect you to be able to have them fused. You as a surgeon have an expectation to be able to do this procedure in a reliable and facile way. And one of the offerings that NanoBone has is to try to fill that void. Your hospital, if you're a part of gain sharing or you're part of the team that focuses on the cost of your procedure, if you participate in bundles or participate in any way to try to lower economic costs, or even if you're a good citizen and try to do that, trying to expose a patient to the hazards of a bone morphogenic protein and or the risks of obtaining autograft from the iliac crest have to be weighed. And so that's why I present this case sample. So this is, again, a patient with 2-level disease. Next slide, please. Who ultimately underwent a TLIF. And so while people can debate about what the fusion rates are for a TLIF versus an ALIF versus a lateral, I would argue to you that that patient who had substantial foraminal disease, one of the ways that I teach and one of the ways that many surgeons try to eliminate the concern about the foraminal disease as a problem is to remove the facet joint. You can debate the technique one way or the other, but you would, as a critical person who would look at bone fusions, you would say that that creates a harder fusion environment. Add to that times where people try to induce more lordosis, removing both facets, the demands of the patient, the demands of the surgical technique make it more difficult for a bone product to work in a reliable way. So this is a 1-year x-ray of this patient who has interbody devices. They're hydroxyapatite impregnated PEEK cages. And I think Steve may have already alluded to, but may allude again at the end of the discussion about the properties of NanoBone being a material that, as opposed to being repelling of water, which is hydrophobic, it attracts water, which is hydrophilic. The cage that I demonstrate here is attracting water, hydrophilic. So does the bone product. This allows for the bony material to try to develop and for the fusion to take place. Next slide. And so this is 2-year outcomes of the same patient, demonstrating no loosening and demonstrating radiographically density within the interbody devices, and anteriorly, which we would refer to as sentinel bone grafting, bone incorporation of the implant and the bone grafting material. So I actually like that idea. I think the fusion devices that we have are great. I think there's some material properties of them also that would be unique to the handling properties of NanoBone. So I saw one of the laterals that Mike had up, which was looked like a 3D printed lateral cage. And I can tell you from my own personal experience that those are very difficult to pack. I can tell you that packing even posterior interbody cages like this, which have a small grafting window, packing what would be meaningful and useful bone grafting material into that device can be difficult. And I think that NanoBone is uniquely positioned to try to help us as surgeons with that. Next slide, please. So we showed a lumbar case. Here's a cervical case. This is a patient with multi-level cervical degenerative disc disease with radicular pain. So a combination of neck pain and radicular pain. Next slide, please. Flexion extension x-rays. Next slide, please. And so what's interesting is this patient has substantial left-sided arm pain. This patient saw a neurologist, saw a hand surgeon, certainly no central disease, but substantial foraminal disease. Due to the patient's neck pain, we had offered the patient a fusion. So again, combination of neck pain and foraminal disease. One other option would have been posterior cervical foraminotomies, but but based on the patient's demand for a potential treatment to address their neck pain and a discussion, the patient had a multi-level cervical fusion. Next slide, please. So what you see is 1.5 years clinical radiographic outcomes. The patient has been done very well, resolution of the patient's arm pain. And what you see is at least radiant density to imply incorporation of the bone grafting material through the interbody devices. I don't know how familiar everyone is with fusion rates with regards to even single level cervical fusions. And we all have a very positive spin, or at least a very positive take as to the fusion rate for cervical fusions. I can tell you, having been author on some of the long-term data as control data for the disc arthroplasty studies, such as the Bryan study, it's actually very surprising that if you look critically at fusion rates independently, so like with MICRA and medical metrics, the fusion rates at 1 year are at least radiographically surprisingly low. I mean, we always tout in the high 90s. You can find studies that will show down below the 70% range for 1 year. That doesn't mean they won't fuse at 2 years, but there's striking radiographic evidence with this product about bone incorporation. Particularly at risk is the caudal level in a multi-level cervical construct, and we see no signs of failure and signs of bony incorporation on these particular x-rays. Next slide. Flexion extension x-rays showing no instability. Next slide. And finally, here's a 60-year-old with complaints of back pain, long-standing leg pain. Next slide. The patient had 2-level disease, combination of foraminal stenosis, lateral recess stenosis, at 3445, Facet disease. Without frank instability, I always discuss with patients decompression alone versus decompression and fusion. I counsel them about the risks of having a fusion procedure. If it fails, they may go on to more surgery. If it succeeds, they may go on to more surgery with adjacent segment disease. And even if their fusion is successful, they may run into risks that they don't have resolution of pain. That being said, it's a discussion about bone graft. So the discussion here is that in a potentially adverse host, how does the bone grafting material function and work? Here's the next slide. And so this patient had complaints at 4 months after surgery. So the patient had resolution and then had a return of symptoms. And so as a precautionary tale, we obtained a CT scan, and we advantageously look at the CT scan to see if there's bone grafting material through the interbody devices. And we see that there's, even at 4 months, there is a substantial amount of radiant density in the interstices of the interbody device, as well as in the sentinel graft, just like Mike had described, bone grafting material that he and I place in front of the interbody device. Next slide. So this is 1 year after that, still no signs of loosening and increased radiant density through the implants. Next slide. Flexion extension x-rays showing no signs of instability. Next slide. So we've heard a bit about what makes NanoBone a potentially better option. For bony healing, you need a variety of factors. I always make an analogy to my residents and fellows about it being like farming. You need everything. You need viable cells, you need a scaffolding, and you need a good host environment. NanoBone offers the bioavailability of hydroxyapatite, a bone structure with a silica that makes a negative environment. Negative environments tend to attract more of the environmental properties that allow for bone healing and bone growth. And what we see is as we've seen in the case examples, clinical and radiographic findings consistent with bone healing, even early on. For full disclosure, the cases that I selected literally were off of a surgical log. I didn't go hunting to find ones that were good, bad, or in between. I picked 3 of them that were degenerative cases that would fit in with the audience. So those are my cases.